So good afternoon, everyone, and thank you for joining us. First of all, I am Mo Carland with Maine Healthcare Association. Today, in addition to our esteemed presenters, I am joined by my colleagues from DHHS, others from Maine Healthcare Association, and Maine's Long-Term Care Ombudsman Program, who have all joined forces to support nursing facilities through the Quality Improvement Initiative known as QuEST, Quality, Excellence, Staffing, and Teamwork. As part of the new nursing facility reimbursement system, Maine nursing homes have an opportunity to earn a share of an $8.1 million quality bonus pool through the new value-based payment program, made possible through the Nursing Facility Transition Fund. In 2025, payment is based on participation in quality improvement initiatives rather than on performance of the selected quality measures. Today's QuEST call does count towards your facility's 2025 participation requirements. In case you missed it or you need more information on the QuEST partnership, please email odes.nfquality@maine.gov. We are excited to have you all here today, and to ensure you get credit for your attendance, we ask that you turn on your cameras and add your name to the nursing facility you represent in the chat. It's especially important for the designated quality champions, or if we can't tell who you are by your Zoom screen name. I want to emphasize this point. Please make sure we can identify you and what facility you are representing when the team is tracking attendance. If your name and nursing facility are not included in the chat or in the attendance logs, we have no way of knowing that you attended. As a new feature, ODES is offering certificates of attendance for licensed administrators attending this call upon their request. If you'd like a certificate of attendance for this call, please again email odes@nfquality@maine.gov. Please only submit a request for a certificate if you are a licensed administrator and you attend the entire call. There is no partial credit certificates issued. For your knowledge, this meeting is being recorded, and these recordings, as well as the slides, will be posted to the Rate System Reform website, which Amanda will drop in the chat. The material will also be added to the SharePoint site and will be distributed to QuEST members via email. If for some reason you are not receiving QuEST updates, again, please email odes.nfquality@maine.gov. The goal is to share information, but also to hear from all of you, the local experts, on some of the best practices that you're implementing for your specific center. So we really want to make sure we're hearing from you. We want to make sure that during this presentation, we're encouraging questions. We want that interactive dialogue. Please put questions in the chat or comments, come off mute, raise your hand. The purpose is to be interactive. So before we move into the presentation, I'm going to introduce Olivia Alford, who's joining us from the Office of Maine Care Services with a brief update on Maine's value-based purchasing initiative. Olivia?
Thanks, Mo. And I feel like you have the best voice. You could be like an announcer for anything, and everyone would listen to you and do exactly what you say. So that's great.
Thank you.
Hi, Olivia from Maine Care. I just wanted to follow up quickly on conversations we've been having in the past about the CoreQ resident and family experience survey, and what would be the allowable methods of administering that survey, so that you all can plan for getting under contract with a vendor to deliver those surveys in 2026, because that becomes one of the performance measures that we'll be using when we're actually measuring performance starting in 2026. So quick advocacy on your all's behalf. The Maine Healthcare Association and the department have connected since the last meeting, and we understand that there was remaining pushback given for why the group wanted to advocate for phone surveys to be allowed. And long story short, we're going to allow phone surveys to be used for CoreQ. So thank you for the continued conversation on that front. Your the argument was well made. We will just go ahead and do that right off the bat. So the rulemaking that's going to go forward in the next coming months, that's really the next step, is you'll see an official Maine Care rule about the value-based purchasing quality bonus pool in 2026 and 7. It'll include phone-based surveys in addition to text, email, and mail. So that was it, just some good news. And I'll hand it back to, actually, I'm not sure who I'm handing it back to. Is it back to you, Mo?
And back to me, yes. Thank you. We definitely want to express our gratitude to ODES for listening to that feedback. Appreciate you hearing the concerns that we had. And just so that people know, there will be, we are putting together a list now that we have these final details, and I'll put some information out in e-news this week, but we'll also be sending out some further information on this subject. So again, thank you so much. So let's jump right into today's presentation. Today is the Dementia Care Partnership Program. And we have an incredibly talented speaker today. Josh Clodius is a licensed nursing home administrator in Rhode Island and Massachusetts. He has advanced skills in quality improvement, technical support, and education. Through many years of experience with the QIO, Health-Centric Advisors, he's been highly engaged with them. Many of you have heard him speak many times. As a nursing home administrator, he was able to achieve excellent clinical outcomes. He built the morale and skill of teams and was responsible for rebuilding and stabilizing his facility staffing level. As a quality improvement specialist, he has worked with hundreds of providers throughout our region, offering technical assistance and support in the areas of quality measures, improving star ratings, NHSN reporting, care of those with substance use disorders, and an array of geriatric and operational issues. Today, Josh is going to be helping us to truly understand the 5-star rating system. One of the things that we all know is that if you're not measuring it, how do you impact it? So having strong dashboards and ways of measuring is imperative to how we improve quality. So I'm going to turn it over to Josh. And again, please feel free to come off mute, raise your hand, drop questions or comments in the chat. We're fortunate enough to have Josh join us today as such a great expert. So thank you, Josh.
All right. Thank you so much, everyone. And like it was mentioned earlier, I would really appreciate everyone to feel comfortable to chime in chat, even to come off mute if you'd like, raise your questions, have a conversation with me. I really am trying to make this like a no judgment zone, so no question is too silly. We're all here to learn, and importantly, you can learn as much from your peers on this call as you can from me. So let's get started and make sure you can all see this screen here. Is my presentation? Yep. Okay, perfect. All right. So yeah, the presentation had come up with the name "The Science of the Stars," and like Mo mentioned, understanding the system, the 5-star system, and the nuances behind it is really how you're actually going to be able to improve it. And it's actually, I look at it as kind of like a science, and I'm going to walk you through the way I work on quality improvement as far as the 5-star rating and my approach that I take, even with my technical assistance that I provide within to the nursing homes. So some learning objectives today, really just to review the system and resources that are available to you. We'll also identify the quality measures themselves, and importantly, how residents actually trigger for quality measures. We'll then dive into how you can develop some confidence and know how you can play with some data to identify your areas of opportunity for maximum impact in improving your overall 5-star rating. And then from there, take it to ways that you can identify specific residents that you can work on for your improvement efforts. So I'd like to open up just the floor for a moment and have our first polling question. How important do you think the 5-star rating is to the public, your consumers, families, patients, etc.?
Is
One
there a
second,
way?
Josh, I'm getting that up there.
Yeah.
Thanks, Amanda.
All right, perfect. So we'll give it a moment to go through it. and to get everyone's feedback. The question should have popped up on your Zoom screen. Just going through chat, I see a couple of somewhats, a lot of varies. Thankfully, no input, not very. So everyone recognizes that it is there is importance to it. And Amanda, I don't know if you're able to pull up the results for that afterwards. All right, perfect. All right, so we get a mixed bag. We did get a couple of not very important, but mostly very important, and 30% saying somewhat important. So the 5-star system, while it is what I would say somewhat flawed, it's actually used significantly by the public and even hospitals, insurance agencies, in determining like your insurance rates for your facility. The 5-star system really is sort of the public face of what you have for your facility, as it's public facing. So while some of you may not think it's as important, I would lean personally toward it being very important, and I'm glad that others recognize that this actually means something to folks when they're determining, who they're going to send their loved ones to. You have someone who's been admitted to the hospital, and the hospital liaison is working with them to try to find placement, and you have a 2-star facility and a 5-star facility that's presented to them. Even at face value, just looking at 2-star versus 5-star and not even anything behind it, you're gonna, those people are most likely gonna try to say, well, why I'd like to go to the 5-star one. So the 5-star system really, again, somewhat flawed, but I think it's so important to have some good facing data, and making sure that patients, families, and everyone can have some confidence when they're deciding to send their loved ones to the facility. So let's go into the 5-star rating itself. So if you're not familiar with the 5-star rating with CMS, there's 3 categories that go into the making of it. The health inspections rating, which are measures that are based on outcomes from your state and health inspections. You also have the staffing, which is measures that are based on your nursing home's staffing levels. And then you also have quality measures, which are measures that are based on your MDS submissions, as well as claim-based quality measures, which are derived directly from claims. You can
Sorry,
see all of
Josh,
this information.
real quick, I'm sorry. We just got a comment that it's a little bit hard to hear you. I just wanted to mention.
Is it something in the background that you're hearing, or is it just my voice that's pretty low?
No, maybe just your voice, but I hear you better now.
Hey, Josh.
Yeah.
Right there on my panel is a set of headphones with a microphone. I don't want to freak you out, but if you want to.
Yeah.
Yeah, I won't do that. Okay.
Find it.
Come closer.
I don't see it.
Okay,
But I'll
sorry for the interruption.
yeah, I'll try to lean in a little bit closer to the laptop. Is this a little bit better?
Yeah, I think it's better. Folks, can you hear now? Yeah, we got some thumbs up.
Yes.
Thank you,
Okay,
Emily.
perfect. All right. Well, thanks for letting me know. I appreciate it. Certainly didn't want you to go through this entire thing not being able to hear me. So again, just to recap, the CMS 5-star rating, it consists of 3 categories. Number 1, the health inspection rating, which is based on the outcomes from your state health inspections. You also have the staffing rating, which are measures based on your nursing home staffing levels. And you also have quality measures, which are measures based on your MDS submissions, as well as claims that are pulled, quality measures, excuse me, that are pulled from your claims data. And all of this together gets added up into what's called your overall 5-star rating. Now, all of this information is publicly available. You can go on to carecompare.com .gov with CMS, and you can actually be able to plug in the state that you're trying to find a nursing home in, plug in the nursing home's name, and you can find their quality measure data, their staffing data, health inspection data. You can actually look at the 2567 forms that the Department of Health surveyors have issued to the facilities and see what specific citations that facility had received for their most recent survey. So it's actually pretty useful to be able to see that, especially if you're familiar with the setting. You can do some digging, and if you have a facility down the road that are 20 minutes away, in this case in Maine, you can look at your competitors or another facilities. If they had a recent survey and it was posted, you can actually see what are the surveyors looking for, or what do the surveyors look and find at down the road, because that might give you some information about what to better prepare or double check on within your own facility as well. So pretty handy to have a good understanding of the Care Compare website and how to navigate it, because it can provide you with a wealth of information. So this is how you actually calculate the 5-star rating. So you start with the health inspection rating. That's really the most important thing to have a solid 5-star rating, is to have a good survey. But those come far and few between. They're supposed to be done every 9 to 15 months. I know some states have fallen quite a bit behind with the pandemic and doing those surveys. But I know at least in Massachusetts, off the top of my head, I know they're caught up with their surveys as well. So making sure that you have a good health inspection rating, good survey, you're able to add a star to that health inspection rating if your staffing rating is 5 stars. But if your staffing rating is 1 star, you're actually having a star subtracted from your total, unfortunately, in that case. Again, the overall rating can't be more than 5 or less than 1. And then step number 3 is you're able to add an additional star if your quality measure rating is 5 stars. And again, in this case, subtract 1 star if your quality measure rating is 1 star. So if your health inspection is 1 star as well, just to note, then your overall rating can't be upgraded by more than 1 star, either from your staffing or your quality measures. The highest you could be in this case is a 2 star if your health inspection rating was a 1. And suppose you had like a 5-star quality measure, you would only be a 2-star facility. Important to note as well that effective with the July 2025 refresh, CMS is implementing a change to the methodology. With the health inspection domain, it used to utilize the 3 most recent health inspection surveys to create that rating. Now it uses the 2 most recent standard health inspection surveys to calculate that. CMS is still going to continue to use a 3-year look back period, however, for any complaint and infection control inspections. And do I have any questions about how the 5-star is actually calculated from this slide here?
I don't
Right.
see any questions in the chat, Josh.
Okay, excellent. So a couple of things to keep in mind too, especially as we're looking at Care Compare website. There is something that's called a special focus facility, and the special focus facility are nursing homes that have been consistently providing poor quality of care. They end up on this special focus facility list from CMS. These nursing homes typically have more problems than other ones. They usually have about twice the average number of deficiencies. They're usually experiencing more serious problems than other nursing homes as well, including harm or injury experienced by the residents, and then a pattern of serious problems that persisted over a period of time. These facilities are actually flagged on Care Compare website with that yellow warning sign, and a lot of their information is suppressed on the Care Compare website. So as the population, the families continue to get more tech savvy. We're having more residents that are getting admitted younger and younger as well. They might be more inclined to more regularly scope out facilities using Care Compare, and this is definitely a huge warning sign for them to stay clear from your facility. Another flag too is that you can find on Care Compare is the abuse sign right here as well. I'm not going to go through all this information is here, but facilities will clearly be flagged on Care Compare as well if they've been cited with abuse citations. And you can see the specifications for that on the slide here. What's interesting to note too is that nursing homes that receive the abuse icon have their health inspection rating capped at a maximum of 2 stars. And due to the methodology used to calculate the overall rating, the best overall rating a facility that receives an abuse icon can have is 4 stars. Again, because if they have a 5-star staffing rating and a 5-star quality measure rating, because their 2 stars is capped for their health inspection, they're still able to add those 2 stars to their overall rating. So just in this case, a facility being a 4-star, you might say, hey, 4 stars is pretty good, but that's just the way that the system is able to work. And all things considered, this facility may have had serious issues with abuse. So just to keep that in mind. Now, as we move on, there is actually how CMS actually bases the 5-star quality measure rating with the health inspection domain is actually within each specific state. So that approach helps control variation among the different states and the various quality among them. And CMS determines facility ratings using these criteria. So the top 10% facilities in each state have a health inspection rating of 5 stars. The middle 70% of facilities receive a rating of 2, 3, or 4 stars, with about an equal number, approximately 23.33% in each. And then the bottom 20% of facilities receive a 1 star. Now, you'll have to keep in mind that as inspections are happening, your facility might be in that 10%, top 10% of facilities within Maine, but that 4-star facility might have had a really good survey, and even the year before that it was really good as well, and that facility now maybe got bumped up to 5 stars and now is included within that 10%. That means someone who was in that 10% now may have found themselves dropped down into that middle 70% of facilities. So the 5-star rating is in flux as surveys are conducted, as quality measure ratings are refreshed on a periodic basis as well. So you have to keep in mind that everything is subject to change. Again, most important thing is try to have a phenomenal survey because that's going to be your bread and butter for increasing your overall 5-star rating. So again, just to reiterate, rating thresholds are recalibrated each month so that the distribution of star ratings within states remain relatively constant over time. And again, the rating for a given facility is held constant until there is a change in the weighted health inspection score for that facility, regardless of changes in the statewide distribution. Ultimately, since those surveys only happen every 9 to 15 months, what can we do? Number one, we can increase our staffing and quality measure rating to improve our overall health rating. If we can get those to 5 stars, if our survey maybe was okay, if we only got a 3-star rating for our health inspection survey, we can potentially still become a five-star rated facility if our staffing levels at 5-star and our quality measure ratings at 5-star. Being a nursing home administrator myself and just knowing how the industry is, staffing can be really challenging to move just because of industry challenges with staffing as a whole. But quality measures we can absolutely influence with better clinical quality, taking a look at tackling system issues that we might be having in our facility, and again, understanding how we're able to actually move our quality measure rating itself to get to that 5-star rating. So quality measure is really the most tangible thing you're able to move on a regular basis compared to that health inspection rating. So let's dive a bit deeper into the quality measure rating itself. So the quality measure rating is an overall score that consists of both your short stay quality measures and your long stay quality measures. So a resident, to be considered in as a short stay resident for your quality measure rating, they needed to have been in your building for at least 100 days or less. Any resident that's been in the facility for 101 days or more is included in your long stay quality measure rating. What's interesting to note is that each of the quality measures themselves have a maximum score of either 100 points or 150 points. And depending on the quality measure you're looking at, it's going to be different. You can see some of the quality measures here: percentage of residents who need help with ADLs, percentage of residents who've received an antipsychotic medication, percentage of residents whose ability to move independently worsening, so on and so forth. So each of these quality measures, you can potentially get up to 150 points depending on how well you are doing in that quality measure. We're going to get into a table so you can have a better understanding of what I'm talking about. Here's an example of just some of the quality measures are with a maximum of 100 points, some long stay and short stay measures. Again, really important that you don't leave easy points on the table that we can ultimately use to improve our quality measure rating. And I'm going to get to that in a second. So all these points that I was just talking about get added up into point thresholds. And this table that I have here is from January 2025 that I pulled from the July refresh. So I don't think the threshold has been updated since January. But depending on both your long stay and short stay quality measure, total amount of points, your facility is gonna fall within this rating threshold. So say maybe your long stay quality measure, you have 1,000 points. Your long stay quality measure rating is going to be 5 stars. But let's say maybe your short stay quality measures are not doing too good. You might be within like the 500 range. So what you do then is add 1,000 plus 500, and that puts us in this 5-star overall rating. Everyone following me so far? Looking for some head nods. Yep. Okay, perfect. And again, if you have questions, please stop me. Let's have a conversation about this. So having an understanding of what these thresholds are periodically updated. So you want to keep in mind that information as you're looking to calculate your own quality measure rating. What is an amazing resource that I'd like everyone to be familiar with is actually the MDS 3.0 quality measure user manual. This is a phenomenal resource, something that I continue to go back to myself on a regular basis, because what is in this resource itself is actually how the quality measures are calculated. So this is It breaks down each of the quality measures, who's included and who specifically triggers. They tell you what the measure is, that this is specifically percent of residents who have had a catheter inserted and left in their bladder for a long stay resident. This measure reports the percentage of residents who have had an indwelling catheter within the last 7 days. It tells you who's included in your numerator, who's included in the denominator, any exclusions that would exclude a resident from being part of this quality measure. And importantly, it also shows you where in the MDS that is the quality measure is pulling this information from. So being able to identify what the quality measure, where to look at in MDS, making sure that that's right. Because of course we want to make sure our coding and everything is not only correct for on a clinical standpoint, but it's also related to reimbursement as well. So making sure your MDS data is accurately submitted, you can actually see where in MDS it's pulling all this information from. So quality measures again can be reviewed within the iQuEST system. Some of them are claims based, so you're not going to be able to see that within a quality measure report. There should be maybe I think some claims reporting that you'll be able to pull in iQuEST to be able to look for some of those measures. What you'll want to do as we take this whole journey of improving our quality measure rating is we really want to be aware of what our quality measures are. What I would recommend is I would pull your quality measure data on a monthly basis. You can specify within the iQuEST system the date range that you're looking for. Do like month by month at a time. Notate which quality measures are below average for you, which ones that are flagging for your building. Explore any MDS coding accuracy. If coding is an issue, make sure that you get any training or provide any support that you need for your MDS coordinator. And then if coding is not an issue, then you know that this is a poor quality measure and it's a true quality issue that we can utilize and incorporate into our QAPI program, create performance improvement projects for any of those flagging quality measures.
Josh, quick question.
Yeah.
Oh, actually, we've got a couple. Okay, question on 2 of the LTC quality ratings. If a nursing home resident's decline in mobility in ADLs, how do we address this in our LTC unit? It seems sometimes it is natural to decline and should not necessarily affect our quality measures.
Yeah, so I know this is a big issue within a lot of facilities where they might not have an adequate payer source to get therapy to support or at least stop any significant decline in mobility. What you could try to do to support is implement maybe like a walking program with some of your residents, making sure and trying to support them so that decline is not drastic. I don't know off the top of my head what the specifications are for that specific quality measure. If we pulled up that resource that I had just mentioned back, we can actually see who would be included. And I think there is some nuance as to how someone is flagged. And I believe it's related to the severity of the decline within a period. Not necessarily because of that declining. But I would have to double check. I don't know the specifics off the top of my head of how someone triggers for that quality measure.
Yeah.
Follow-up question on that, Josh, and perhaps this may be a detail you don't know, and it sounds like we have another question after, but are hospice residents included, or is that exclusion criteria?
That would I would have to refer to that manual again. There's so much information about all the quality measures, about who's included, who's excluded, and it's all very clearly mapped out in that resource about who's included, who's excluded, and all the information. I'm sorry to say that I don't have that memorized.
Well, it's a lot of quality measures, so,
Yeah.
you know, and memorize all of the exclusion criteria off
Yeah.
the top of your head would
Yeah.
be impressive at least, but maybe even disturbing.
Yeah.
I'm sorry, Lori, did you have a question too? Nope, she's good. Okay.
Okay. Okay. I think, all right, I think we're caught up now. So this brings us to our second polling question. So what I'd like to ask all of you today is, do you know the specific measures that are preventing you from increasing your quality measure rating right now? And let me expand upon that a little bit. I don't mean knowing when you looked at your last CASPER report, which quality measures are flagging with that black asterisk and bolded because your facility's in the 75th or higher percentile. I'm talking about, do you know which quality measures are just a cusp away, potentially, from moving into the next point threshold to give you more quality measure points?
Response is still rolling in. Everyone, I'll
Alright.
leave that up for about 10 more seconds. And they're slowing down. All in the pool. There we go.
Cool. So I know there was a lot to emphasize about what specifically I'm looking for. And I saw someone comment, like, I said yes, but now that I had expanded upon it, no. Yeah, I'm glad that folks have a general idea of what quality measures specifically they should be working on. But what I'm going to show you folks is how you can actually hone in on it even further and know it at a very specific detail about what you need to do to improve your quality measure rating. So thank you everyone who participated in that. So next steps from here, when you're reviewing your quality measure rating and determining, how you receive your current score, you can look deeper in your CASPER reports and look at some of the cut points that there are for each of the quality measures to determine where you have your opportunities to improve. So in this case, this facility's CASPER report, really struggling with antipsychotic measures. You can see that they have 33 out of 72 residents that are triggering for the long stay antipsychotic quality measure. Their facility observed rate is at 45.8%. And these are the point thresholds for the percentage of residents who received an antipsychotic medication for long stay. If you have between 0 and 4.78% of your residents receiving an antipsychotic medication, you're going to get the full 150 points for this quality measure, having a very low antipsychotic medication utilization rate within your facility. You're going to get the max amount of points for that measure. In this case, with this facility, we can see that they have 45.8% again. And this means that this facility is only getting 15 points for this quality measure out of a possible 150. So there's a significant opportunity for this facility to be able to capture more points by improving this quality measure. And maybe for this facility, they have a lot of residents with psychiatric diagnoses where it would be appropriate for them to receive an antipsychotic medication. So maybe getting 150 points for this quality measure is impossible for this facility. But maybe it's possible they can drop it down to enough where they can get 30 points or 45 points and be able to get more points that are going to contribute to their overall quality rating. I have a tool that is going to be updated, hopefully, with the continuation of the QIO contract that's currently on hold. But you're able to actually plug in your facility observed rates for all your quality measures, and it highlights and shows you how many points you're getting for each of these quality measures. It tells you you have a 4.4% observation rate of falls with major injury for your long stay residents. That falls within this point threshold, you're getting 40 points for this quality measure. And it adds this all up for you to show you what your star rating is for your long stay, your short stay, and your overall based on the overall points that you're receiving. And I have the calculator up with another example that I can show you about how easy it is to use, if you don't mind me just switching my screen for a second.
Yeah, that would be great, Josh.
So I have this example right here. This facility's total quality measure score is 1,221. And their overall quality measure is 3. So you can see they fall within this point range. So they are 121 points shy of eclipsing this threshold to then move into the 4-star overall rating. So what happens if maybe over the course of the next year, they get 0 falls? So we change that to 0. Now they're getting 100 points. And maybe their partial ulcers, they were able to get down to, 2.5%. Now they're getting 100 points here. And now it calculates everything for you. It changes it. So now we're showing that the facility becomes a 4-star overall quality measure rating. This is very handy. And what I really would encourage folks to be able to get comfortable with is playing with your data. You should be able to look at your facility and say, hey, we have 25% utilization rate for our antipsychotics. If we drop that down to 17%, 20%, how many more quality measure points would we get for that? And importantly, does that help us get to the next thresholds for our star rating? And if not, what other areas or what other quality measures can we work on to have sort of an aggregation of marginal gains? So it might be really hard to move one quality measure, but being able to move that to be able to get 15, 30 more points, it may be something that's achievable. But what about all the other quality measures that you have there? What if we can improve just a little bit here? What if we improve a little bit here? And collectively now, where we've gotten 150 or 200 more points, that puts us now into the next increase bump up in our quality measure star rating. But knowing even before that is playing with your numerator and denominators. Like if I have 20 residents that are triggering for antipsychotics, if I bump that down to 15 and do the math with your numerator and denominator, what is my new observed rate? And if I can get to that, let me plug that in, see how many points that I'm getting, and then, get really comfortable with being able to play with this data and look at everything in a hypothetical lens, because it's going to be able to show you where your areas of opportunity are and what are the low-hanging fruit for you to be able to achieve that higher 5-star quality measure rating. Amanda, I see that your hand's raised.
Sure. So folks are piping up in the chat. They asked it. Do you have a link to this? And if so, I can either put it in the chat or I can share it after the call.
Yeah, so like I mentioned, the link that I have, unfortunately, is these thresholds and point thresholds are all dated. Has yet to be updated right now. I'm hoping with the because currently the QIO contract is in protest for Region 1. I'm hoping that once that is resolved, we can get this calculator updated and into everyone's hands. But honestly, I would be surprised if ACA doesn't have something similar on their end. So if any of you want to check maybe with your contacts from the national level to see if they have something like this on their back end.
Yeah, actually, if you go into your top line report in long-term care trend tracker, you may find something very similar to this. If you need any help with that, just let me know. I'm happy to assist people.
Perfect. Let's see, I'm just going to glance over chat too to see if there's anything. So Janet says, show us where we change the numerator and denominator. So in this calculator specifically, it's only, you're just putting in the percentage of your facility's observed rate. You're actually going to need to do the math yourself about, you know, if we go from 20 to 10 for our numerator and, you know, our denominator doesn't change, that would be a reduction. You're actually going to have to do, you know, the division for those fractions to be able to get those hypothetical observed rates. And let's see. Okay, I think that's it. So again, emphasize, I really encourage everyone to get really comfortable with playing with those hypothetical scenarios and in data. So because it's going to be really helpful in helping you get to where you need to be. So another question I wanted to ask as well is, do you know how to access and use iKeys? I know just from speaking with a lot of facility administrators, some don't know how to get any reports or how access the system. They usually just rely on their MDS coordinator to pull everything. And no judgment either way, but I'm just curious to know how, if folks know how to access and utilize it.
Questions are the responses are slowing down. I'll give it just another few seconds. All right, we'll end the poll.
Okay. Okay, so good mix, pretty close to even, but majority within the no. So good, because I'm going to provide you some information on how to be able to navigate it. So once you're in the iKey system and getting set up with that is another question that I didn't allude to, unfortunately, in this slide deck, not that I'm thinking about it. But once you're actually in, how to actually be able to pull reports to make this system useful for you is that once you log in, you click on that drop down that hit reports and click find a report. From there, I just put in the nursing keyword because it's going to pull up a lot of reports related to nursing home, related to your nursing home and clinical data. So you just plug in nursing and then hit that find report. And then you're going to get these search results that come up. It's going to show you a list of all the reports available to you. When you click on your report, from there, it will be included in your frequently used list and will be a lot easier to locate in the future. But getting those, doing it for the first time, you're going to have to do a little bit of this legwork. But you can just see from some of the results here, you can see your admissions and reentry discharge report, your facility characteristics report, which is going to provide you with demographic information, you know, the age ranges, the male versus female, etc. You're able to pull your facility level quality measure report, which is what I had shown earlier about the facility having that 45% observed rate for antipsychotics. You also have nursing home MDS 3.0 nursing home error detail report, which can be utilized to provide you some errors that were encountered in your MDS submissions. When we move on from here, again, here's what their frequently run report screen looks like. Once you've run the report for the first time, you'll have these reports that you're able to access, something that you'll be able to just log in, click on reports, click on the report that you want, and then plug in the specific date range that you're wanting to pull the data for. So you can specifically specify the time frame for the report that you're looking for, save the report and download it. Again, I like to look at things at a monthly basis. You can actually use your quality measure and claims data to calculate and forecast what your 5-star quality measure rating is going to be, because what's publicly available on Care Compare is there's a lag behind it, so they're not looking at what's currently going on in your facilities. So once you get really good at this information, you could even forecast and show us and show yourselves, like, right, if when we're using this month's data, we're looking at, at a 5-star quality measure rating based on our quality measure data. So it'll take some time to get comfortable doing it, but you're able to be able to forecast using your live current data within the facility before it's even publicly available, to know what your facility is going to end up with later on once that publicly reported data is made available. So I've told you how the quality measure, how the 5-star rating is calculated. We've talked about the quality measure rating, the quality measures, the points associated with them, what some of those thresholds are, and how each quality measure has different thresholds, and you can get different amount of points. I've talked to you about utilizing tools like this calculator to be able to play and get comfortable to identify where your areas of opportunity are for your quality measures. And now I want to take it to the next level, where you can actually work to identify residents at the resident level to know who you should be specifically working with to improve your quality measure rating as well. So I have this facility CASPA report right here. And what I like to do is I like to just first highlight on the left any quality measure that any resident that has 3 or more quality measures that they're triggering for. This is something that the surveyors do as well. I'm not sure if they go by the number 3 or something a little higher, but they actually will pull your resident level data before they go into your building, identify residents that are having significant clinical issues where they're triggering for 4, 5, 6, 7 quality measures, and work and review those residents. So I just, as a good practice, is I take a look at all the residents that are specifically triggering for 3 or more quality measures and make sure to highlight them. And then for a specific quality measure that I'm working on, I then go in and highlight all the antipsychotic medications. So this resident triggered for long-stay antipsychotics, this one, this one, this one, and this one. And what I start to do is, as I'm working through this resident level CASPA report, is I start to notice some other things that are happening. A lot of the quality measures have a domino effect upon each other. And when you improve in one quality measure, you can often see an improvement in some of the other quality measures as well. Conversely, that domino effect could also be on a negative as well. Antipsychotics, we can often see other quality measures trigger, such as behaviors, anti-anxiety, falls. So I'm working, and I highlighted all these residents that are triggered for antipsychotic medication, and I notice, boom, this resident triggered for a fall. This person triggered for an antipsychotic medication, they had a fall. This person's receiving an antipsychotic medication, they had a fall. This resident triggered for the antipsychotic medication for receiving it, they haven't had a fall yet. So is that something that we need to take a look at to see if maybe this person is at risk for falling? Let's double check that. This person had antipsychotic medication, they had a fall. Again, these quality measures can have that domino effect. Other examples are, if you see a resident who's triggering for a significant weight loss, Are they also experiencing pressure ulcers? Or residents who are having those pressure ulcers, are they also triggering for pain and such? So this is the approach that I take to try to identify how these quality measures are affecting these residents on a grander scale, and trying to take it to a person level approach where my next steps is I can actually put together a performance improvement project and make some resident centered and person centered approaches to not only improve the clinical care for the resident, but also improve the quality measures as well. So ask yourselves, what do the staff need to know? Identify how the measures can affect each other. We've been talking a lot about antipsychotics, and I know that's related to the main value-based purchasing program as well. I just wanted to highlight last year that CMS had started auditing facilities records as to the use of antipsychotic medications, especially when the medication is being prescribed for schizophrenia, as the fear is that this diagnosis is being overused. So if antipsychotics are being used for this purpose, make sure that the diagnosis is confirmed and that the documentation is thorough. The reason that I'm bringing this up is that the quality measure rating, your quality measure rating will automatically be reduced to 1 star for at least 6 months. And from what we're hearing, some facilities are having difficulty having this fixed even after the 6-month period. So you do not want to find yourselves in a situation where physicians are having providing these diagnoses so that you have residents that are not going to contribute to your quality measure, just so that you can do better in that sense. So CMS is taking a thorough look and doing these audits to make sure that there's nothing funny going on. Another thing that you'll come to understand in time too is that some of the quality measures that are relied on the MDS data, for antipsychotics, for example, it utilizes a 7-day look back window. But going forward, with these with the recent QSO that they had talked about, I believe October 29th was the date that they were looking at, but I think they even pushed that back to January, where CMS is actually updating the antipsychotic measure to include additional data from Medicare and Medicaid claims and Medicare Advantage encounters, so that they can capture antipsychotic prescribing beyond the 7-day window. Some of the other quality measures, for example, have a different look back period. So you might have someone, for example, who's triggered for for a fall with major injury for a long stay, and they're going to keep showing up on that resident level quality measure report and be included in that measure because the look back period for that measure is different from some of the others. So just keep that in mind as you're working with and working towards improving your quality measure rating. So here's the QSL that I had mentioned, just some high level key changes that are introduced. They're gonna display some chain level performance data. So for the first time now, CMS is going to begin to publicly display the average ratings for nursing home chains or commonly owned facilities that had started back in July of this year. They had removed the COVID-19 vaccination measures. They revised the antipsychotic medication measure that I mentioned to now include the Medicare and Medicaid claims data that I mentioned, and they had excluded the older survey data, now again using the only the 2 most recent standard surveys to calculate the health inspection rating. So now that we've done all this, we know how the star system works. We know how the quality measure rating is calculated. We know how the quality measures, how each of them have specific points and thresholds attributed to them. We know and are comfortable now with playing with the data to identify areas of opportunity. And from there, we can even identify the residents that are triggering for our quality measures to know who we specifically could work with to improve our quality measure rating. From there, you can put together a performance improvement project. You can do some root cause analysis and identifying any system issues that you might have, or any events to be investigated. You can utilize this template if you don't have something already existing within your facility. You can utilize this. It's a great, maps everything out, who's specifically on the team, who's included in the root cause analysis, the scope and such of it. But there's also within the main dementia care partnership, a lot of quality improvement tools as well. They have the person-centered approach to QAPI, which is a lot of what I talked about today, and more. There's also the main dementia care partnership QAPI dashboard. There's also a lot of forms and resources that you could utilize to your advantage as well. Again, this is just sort of to highlight the resources that are available to you, showing you processes that you can take, indicators that you can utilize, resources at your fingertips to be able to assist you in this quality improvement journey. And Margie and I said if we could rule the world, then there would be a board like this in every single nursing home. This is just an example courtesy of the Iowa Healthcare Association, where this facility had put it loud and proud of all their quality improvement efforts. They named out all the performance improvement projects that they're working on. They talked about the goals, what the processes are that they're taking a look at, the progress that's been made thus far, who specifically is on the team, if anyone had any questions they wanted to ask, the data sources that they're utilizing to inform their improvement process, and the results that they've gotten thus far for these projects. So would really recommend, if you don't have something like this, make quality improvement fun, get people, frontline staff involved in the process. They know so much about your residents. They see so much. There's so much that they can offer, that by doing QAPI as the administrator and the director of nursing yourselves, just going into the boardroom and putting up some performance improvement project to satisfy some paperwork, that's not true quality improvement. Make sure that you get people involved in this process, because they can really provide so much value. I know nursing homes, MARS, care plans, infection controls, like checklists, a lot of facilities live and die by checklists. But sadly, we can follow everything to a T and still fail our patients. What I want everyone to remember is that CMS regulations and standards do not, and clearly from the 5-star rating, doesn't necessarily mean excellent care. It's just the minimally acceptable care. So be sure that you're not using them as the ceiling for your quality improvement, and treat that as the floor. There's so much more that you can do. I'm hoping all this information is going to be helpful for your quality improvement process. Now that you know how to be able to actually move your measures and the science behind it, I'd like you to go out now, utilize these strategies and resources, and go provide some great clinical care. And that's all I have. Thank you so much, everyone.
Gosh, that was awesome.
Awesome.
If maybe people have some questions or comments that you want to ask at this time.
There's one more in the chat too, asked a couple of minutes ago. Besides health-acquired infections, what other infection control measures will trigger?
For which measure?
Yeah, what are they looking for specifically? I know that there are some vaccination quality measures that are shown specifically, like the pneumococcal and influenza vaccination. But even when you look in the pneumococcal vaccination, for example, I'm just gonna pull up my screen for a second. Some of these measures are, this is screen 3. So this is the percent of residents that were assessed and appropriately given the pneumococcal vaccination. So you have residents that would be included in this quality measure if they meet any of the following criteria in the selected target assessment. If their vaccination status is up to date, if they were offered and declined the vaccine, or were ineligible due to medical contraindications. So a lot of folks, they get confused for like this vaccination measure, for example, saying, oh, our vaccination rate is not high for pneumococcal, or could be better. When what the measure actually is measuring is, at a minimum, the people that were offered and declined the vaccine. So we obviously want to make sure all of our residents are vaccinated because it's going to help them with their health. But at a minimum, we need to be offering the vaccine, and if they decline it, that's their right and their choice. So you're not going to get negatively impacted if they decline to take the vaccine, because it's still counting as a positive, because the measure specifically is who were assessed and appropriately given the vaccine. If they were offered and declined the vaccine, they're still included as if they were vaccinated as a positive for your vaccination rate. So knowing some of the nuances like the infection control and the vaccination measures at that level is helpful as well. Maybe it's you have short stay residents who are coming in and they are leaving before you're able to even offer the vaccine, and that's where there's an area of opportunity to capture that. So maybe it's taking a look at your admission packet, making sure that you have the consent form and conversation about those vaccinations before they even come in the building, and right with the admission packet. That's a way that you can tackle that from that end. I hope, not sure if that was what you were referencing, or.
I think the important piece for everyone to hopefully take away from this is that there are all of these measures, and there are technical specifications to these measures. I did put a couple of links in the chat. And when you look at some of those technical specifications, it will help you to drill down as to what is driving your data, and then to be looking at that data. You know, this is a big part of the Dementia Care Partnership program, to really look at your dashboards, your data, how to use data to inform. So I think if we look at Deb's question, I don't know if you want to tackle that, Josh, or you want me to chime in, or Margie might want to chime in as well.
I'm looking for
Yep, I'm sorry, I'll read it for you. Looking for some talking points to support helping providers in avoiding anti-psych prescriptions for diagnoses outside the accepted.
Yeah, so I think one of the biggest things that you can probably do is to have your medical director kind of sit through exactly what we showed you today. Have a conversation with them about this. So CMS only has 3 diagnoses which would exclude someone from triggering for an antipsychotic medication. I believe it's schizophrenia, schizophreniform disorder, and then Tourette's. So unless they have one of those diagnoses, you're going to have your resident trigger for receiving their antipsychotic medication. Now, I'm not a clinician, and I'm sure there's other reasons outside of what CMS says why someone would be appropriate for receiving an antipsychotic medication. I think I would approach this conversation with our medical director saying, and make sure that they have an understanding of like how the 5-star system works, because I've talked with the facilities who their physicians and medical directors don't know any of this information, and the facility is trying to do one thing and the physician's doing another. So making sure you're having conversations saying, hey, we want to improve our 5-star rating. One of our areas of opportunity is reducing our antipsychotic medications. This is how the measure is calculated, and point thresholds and all that stuff. Show them all this information, have the conversation about them, and then say the only exclusions that CMS gives us is these 3. We don't want to lie or say that they have these diagnoses just so that they can be excluded from these quality measures. But these are the things that we want to do as a facility. We want to take a look at the environment. We want to look at non-pharmacological interventions. We want to look at things that we can do without having to prescribe this medication for this resident if we don't have to. And just making sure that they have an understanding about what the measure is, how it's calculated, what the facility's goals are as far as improving the 5-star rating. And importantly, what are the strategies that you're going to do at the facility level to make sure that the physician is going to be confident with you and your team to say, okay, I'll forego not prescribing this antipsychotic medication, and making sure that you are putting sort of the best case why we can go without needing to give this person their medication.
I'll add to that, Deb, as well. If you, and many of you are involved right now in updating the change package, or what we sometimes refer to as the toolkit, as part of the Maine Dementia Care Partnership. If you go to our website, you can find a lot of documents, and we are in the process of updating them, but they do have some links to some good articles and good information as to why these are not good medications. Being an old psych nurse, we know that these were used as major tranquilizers, and often, people feel like they're trying to do the right thing for a resident who is in distress, and we get that. But ultimately, these are black boxed medications, and they're really not appropriate for the population that we serve. So you can kind of try to come at it from a clinical or empathic, and ultimately you may need to say, bottom line here is, if you're prescribing these medications, are going to impact our quality ratings, and in all reality, eventually our value-based payment. Margie, you're the expert. Oh, go ahead, Amanda.
I was just going to say, kind of adding on to what you were saying, Mo, and a big part of the Dementia Care Partnership, right, is what is the root cause of those behaviors? And it's so easy, like you said, to get away from yourself with empathy, from the team, and everybody's just trying to well, why are they blah, 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 and you just go to, behaviors and kind of forget to really ask the deep down root cause analysis of why, are they in pain? Are they uncomfortable? Are they unable to reposition? Are they overstimulated? Sensory overstimulation. So we do have time for more questions. No question is a bad one. We really appreciate this, and I know Josh really appreciates all of your questions. Even if we can't answer them off the top of our head, we can point you to the right resource.
So Amanda,
Are there any thoughts on Parkinson's as an exclusion related to hallucination?
It isn't happening right now at the national level. I think there are a lot of other illnesses that can sometimes cause hallucinations, but it's how do you manage those hallucinations? The other question I see here is the anti-anxiety, and I am not a physician, but I know we all know that there's a lot of again, severe potential clinical issues for people who are on anti-anxiety medications. So they may not be the best choice. And I think, as Amanda said, if we can figure out what's causing, what is the communication?
And so just a couple of things to bounce off of Amanda and Yumo. Specifically with Amanda about those behaviors. In that example that I had shown you about the antipsychotic medications, I looked at also falls just as an example. But look at, and this is taken from a real CASPA report, okay? So you have all these folks who are receiving antipsychotic medications, and they're also triggering for behaviors. So number one, I would need to look at what the look back period is for the behaviors. Number two, my other question is, all these folks are receiving antipsychotic medications, but are they still experiencing all these behaviors? So if they are, what's the point? Why, what we're doing is not working. And so that's something that we need to take a look at. And also switching with, like you said, Mo, antipsychotic medications, there is an anti-anxiety and hypnotic prevalence measure as well. So you're kind of just trading one for the other, and that's not going to really make an impact. And again, the goal is to mitigate unnecessary use. So I just wanted to pull it up to be able to add to what you were mentioning.
Yeah. And I understand one of the things too, as Josh had mentioned, the measure for the use of for antipsychotic use is changing. And unfortunately, what has happened is that there has been some reports through the audits and through the OIG that there's not enough documentation to support a diagnosis. So they're looking not only at they're looking at what are you billing for? What are the diagnoses? What's the supporting evidence of the diagnoses? And we know that we are going to see an increase in the rate of antipsychotic use based on the new data that CMS will be collecting. So really important. And I think we all know clinically it's the right thing to do.
Yeah, and I'm seeing some comments saying acute providers prescribe them without proper diagnosis, and you know, a lot of residents are being admitted with them. There are a couple of things. There are two antipsychotic measures, one for long stay residents and one for short stay residents. So the long stay one that we've talked about a lot today are your long stay residents who've been in your facility for more than 100 days. So anyone who is being admitted into your facility, short stay, that is receiving an antipsychotic wouldn't be included in that long stay measure. And number two, I believe the short stay antipsychotic measure is actually specifies as newly prescribed. And there's some nuances and specifications behind it where I believe it's looking at if the nursing home prescribed it, not necessarily if the hospital did. But I don't know off the top of my head, and I have to check. And like the whole message has been about this entire presentation is that these measures have very specific nuances about what specifically it's looking at and what it's capturing. And knowing that at a very detailed level, or at least being able to know where to get that information, is going to help you on your journey to improve your 5-star rating. What applications do facilities use to help view and see building quality measures in real time? So some facilities with their EHR vendors are able to pull reports based on that information. You're able, I mentioned earlier, iKeys, you're able to go into that portal and specify the date ranges that you're looking at when you want to run a report. For example, if you want to run something for September right now, you'll have to keep a couple of things in mind. Number one, September is not over yet. Number two, you might have some MDSs that haven't been completed or are still in the progress of being done, so they won't necessarily be included in the quality measure rating report that you generate. But you're able to pull your facility's quality measure data straight from iKeys. You shouldn't need any additional outside vendors or reporting. Everything, all the quality measures specifically are pulled from everything you put into MDS and your claims data. And all of that should be available to you within the CMS iKeys portal.
The other thing, and I know that there is some software, and I know many of you use point-click care. I'm sure there's some systems in there that you can use. But one of the things, especially when it comes to whatever it is that you're focusing on from your QAPI standpoint, let's just say it is antipsychotics, is having a PIP that is really focused on that. And so that maybe on a weekly basis, you have the team get together and talk about people who are on any antipsychotics or people who are demonstrating any behavior. Somebody asked about support systems to assist SNFs with behaviors. Actually, it's going to be in this week's e-news. ACA has just come out with a new behavioral health guide. As most of you know, the Center of Excellence for Behavioral Health, their contract ends at the end of September. You can still go on to their website and download some of their documents, but they'll be going away. But ACA does have this new resource, and I put a link to that in the chat as well.
Maureen, it's
Yeah.
Karen Smith.
Hi.
Hi, I just wanted to go back to what you said about having a weekly meeting. We started GDR meetings focusing on antipsychotics, 1 unit at a time. I think of, you can, save 1 starfish at a time, right?
Yes.
And we've met 3 times, medical director, myself, nurse manager, a charge nurse. I'd love to have CNAs there. We've been able, it doesn't sound like a lot, but to discontinue 2 antipsychotics in 3 weeks. In addition to that, we're coming up with plans. We've got to have a plan in place for the next folks that we're looking at. And the enthusiasm of the charge nurse in particular, because buy-in is so important, but it's amazing. And it's because of the dementia toolkit group that you are running that we did it.
Awesome. And I would just encourage you to make sure you have someone from activities involved as well.
Oh, that's
And
a great
then
idea.
I go back to that wonderful picture that I know Josh and Margie love. And I absolutely love it as well. And if you can figure out a way to visually represent the data so that your team sees you're making a difference.
We've got the fish bones on posters outside my
Good.
office.
Nice. That's right. That's
Yeah.
right. Yes.
Thank you so much.
Yes.
I just wanted to thank you too, Karen, for sharing that story. And I think, you had mentioned 2 might not seem like a lot, but I bet you it was a lot to those residents. This is ultimately what we're here for. I've seen residents who, like Mo had mentioned, who are on these medications and are at like a level of sedation where they don't even know what's going on. And when we remove them from these medications, they have life has come back into them, and it's really amazing. So I really just wanted to highlight that you should be absolutely proud with what you've done. Thank you.
And I go to the quality of life. And if you've never seen anyone with tardive dyskinesia or cogwheeling or akathisia, when you think about an older person's grandchild coming to visit them or their great grandchild, and they're 10 years old and they're seeing tardive dyskinesia, what a not the most pleasant way to remember your loved one. So thinking it from moving forward. Any other questions or comments? Great. All right, well, I want to thank everyone for coming. And in just a minute, I'm going to put up a QR code and Amanda will drop into the chat. If you would please do a brief survey. We really want to help gauge what's going well, where we can improve. It's just so important that we know how to continue with these programs that are meaningful to people. After this call, if you have any other questions related to QuEST, please send them to odes.nfquality@maine.gov. Today's recording and slides will be posted on the Rate Reform site. Oh, thank you, Amanda. You're awesome. And it'll be on the SharePoint by next week. If you haven't accessed the SharePoint site yet, we really encourage you to do so, as it houses all the previous call recording, slides, and other resources previously shared, as well as the chat log and attendance list. Cannot stress that enough. If you are covering for somewhere today and you're on this call, make sure you tell us in the chat what center you might be covering. People have days off, people have vacations, people get sick. We want to make sure that people are getting credit. So If you need any new invitations or you have any change in your champions who are going to be attending this, please again reach out to that same email. And all the materials presented today will be sent via email to all QuEST members. And I'm going to put in one more plug for the change packet or the dementia care partnership toolkit group that meets on a monthly basis. If it's something you have a passion about and you want to help us to make that document and that tool as helpful and useful for everyone, please reach out to me. I'll put my email in the chat because I'd love to have you involved in that, and I'll make sure that you're on our distribution list. Thank you, everybody. Really appreciate your time today.